Hello, everyone, and welcome to another edition of FitRx. I'm your host, Dr. Greg Dennis. I have another physician today as a guest. I've been blessed. It seems like here lately I've had a lot of doctors on the show. So I'm very excited about today's guest. It's Dr. William LaValley, and he is a physician and researcher, and I'll let him kind of tell you a little bit about his story. But he got interested in more kind of integrative medicine from the beginning of his training a long time ago, as he was also studying his PhD. And then at some point, which I'm sure he'll go into this, he really began focusing on cancer research. And so he does a lot of cancer research today, and he helps people from probably all over the world and physicians in, um, integrating more kind of holistic approaches and using things outside the box to treat cancer that many times I'm sure complement traditional therapies. But he does a ton of research in that stuff, and so that's what we're going to talk about today. So anyway, I've had seems like a lot or several episodes here lately that kind of we've talked about cancer, as it's obviously important, and so many people are affected today. But so very very important episode today, and so looking forward to hearing what he has to say. So Dr. LaValley, welcome to the show.
I'm glad to be here. Thank you for having me.
So yeah, as I mentioned briefly, you started out kind of from the beginning with an interest in more integrative medicine and research, and it sounds like that kind of shaped you in what you wanted to do. So tell us a little bit more about that, a little bit more about you, and then how you took that and got kind of an interest in the cancer field.
Sure. So it started early in my career. I was in medical school in a PhD MD program, and I got the opportunity to be selected to go to the People's Republic of China on an exchange program. And I was looking at the biochemistry of acupuncture. Excuse me. That's why I went. And when I got there and I saw the use of acupuncture, and I also saw this wide variety of use of herbal medicines right next to pharmaceutical medicines and surgery being performed. It changed my perspective on looking at how to integrate the range of therapeutic tools available. And so I came back and really pursued that. And after a couple of years in the PhD program, stopped that and finished my medical training, finished family practice training, and was invited to a practice. A doctor was about to retire up in Canada. And so I took that opportunity and went there with the idea of staying there for about 3 years to get the equivalent of a residency, because there was no training for integrative medicine in the US at the time. It was a pretty adversarial environment in Texas, where I was from. So I went up there with the intent of staying there for 3 years, and I stayed for 27 years. Still am licensed up there. And along the way, we raised a very high profile for natural medicine alongside conventional medicine. And the Canadian FDA, the Canadian government FDA, appointed me as the integrative medicine medical doctor to develop regulations for natural health product supplements in Canada called natural health products. So in the US, everything through the FDA is divided into food and drugs. So the subset of drugs is supplements, food supplements. I sorry, a subset of foods is food supplements. But in Canada, they weren't going to do that. So they had a third regulatory category that we were pushing for, and subsequently became officially developed throughout the country. And that gave me, from 1997 to 2004, the opportunity to get direct access to the data about natural products in disease treatment. Because in those days, to go get data, you had to go to the libraries. You actually had to go to the card catalog at the front of the library and then the stacks and pull down the article, go to the copy machines, and made it very difficult to get the data. I was able to ask for it and have it delivered to me. So it gave me, in essence, early access to molecular information about the anti-disease effect of natural products that were already on the market, as well as looking at, I was able to access for repurposed drugs as well. And so I started applying it with my own patients who had a diagnosis of cancer. And in the first 5 or 6 years or so of doing that, from the late 1990s, all of those patients were already completed all of their conventional treatment. And what I want to emphasize is this: what I'm talking about, the molecular integrative oncology, is always in addition to and not instead of conventional oncology treatment. And I was applying it in that manner, but they were no longer getting any conventional oncology treatment and were released from conventional oncology, told to there was nothing more that could be offered to them. And so it became a case series of people who were just getting these treatments with significant history of cancer. And not everybody, but significant numbers of people were getting very high quality of life results, essentially living at home, getting their living their full life. Some were farmers, some were fishermen, some were or working in the office or teachers. They lived their life the way they wanted and had extended duration much longer than they were predicted. And that's what we were aiming for, to control the progression of the cancer in such a way as to provide that significantly greater quality of life or significantly extended duration of life compared to those similar group people, their cohort, who have the same diagnosis and who are getting all best conventional treatment and not getting this additional parallel molecular integrative oncology treatment plan.
Hmm. Very good. And so at some point with you doing that, it sounds like you just kind of naturally, uh, kind of evolved to pretty much just doing, cancer treatments and research. Is that correct? Is that pretty much what you do now?
Yeah, the where I had my clinic was a rural community on the South Shore in Nova Scotia, so right on the Atlantic, and small communities, and everybody knows everybody, and so the word started to spread around the provinces and through a very wide radius, hundreds of miles, and so more and more people started coming. And as word got out, they started coming sooner in their course of treatment, and so it was treatment concurrent with chemotherapy and radiation therapy. And then subsequently, what occurred was people were far away, that it was so far, it was very inconvenient for them to drive hundreds of miles. And so they asked for that their local doctors could receive the treatment plans. And so that's what I started doing, is collaborating with local physicians about their patients. And a big difference occurred that I hadn't anticipated, and that was when I would give my patients treatment recommendations, they didn't request or expect that I was going to give them all the scientific support data, the reference citations, the reasons for why I was recommending each item in a very organized, scientifically supported format. The physicians needed that. So that meant that I had to figure out how to get to the data in such a way that I could build databases that would be able to be provided to the physicians for every single recommendation for the anti-cancer use of the natural products and the repurposed drugs. And that sent me down the road of really looking at how can we develop a model, a method for providing these data to make it available at a greater scale, and in an organized fashion that's easy for the physicians to receive and review, They can modify it in whatever way they choose because they're the treating physician. That happens rarely because that's why they're seeking the collaboration, is they want the recommendations that I'm providing. Then they administer it to their patient. We follow up with a very extensive quick start training so that the patient is very familiar with the personalized implementation of the treatment plan, pill by pill, day by day, dose by dose, so that they are able to maintain the treatment plan in a manner that always remains comfortably well tolerated, so that they're able to identify when they reach the threshold of comfortable tolerance for every item in their treatment plan. It's very important, because if they're not able to tolerate the treatment plan comfortably, if they're struggling with it, within a few weeks, they won't be able to continue, no matter how tough you are after a few weeks, or maybe even a month, or some folks maybe a little longer than that. They can tough it out. But if they're not tolerating everything in the plan, then the plan will stop. It'll fall apart. And so understanding how to implement that slow, gentle dosage escalation in such a way as to be able to identify when there's a minor noticeable adverse change, a minor noticeable adverse symptom, to identify the threshold of that particular item. My patients taught me that back and forth in an iteration. Hey, doc, this doesn't work. No, that's it. Here's how I did it. Here's what we did. And so that process evolved and now has become very, very efficient and very refined.
Hmm. I want to take a step back for a minute, and I know most of your focus is on cancer treatments, but obviously you spend a lot of time studying cancer. Um, and I feel like that cancer diagnoses are just coming, so common. I mean, just more and more prevalent. I actually was at the gym this morning and was talking to somebody who's, kind of a mutual person we know, that somebody's wife was just diagnosed with lung cancer, and very young. And so it's just, gosh, it seems like every time you turn around, I mean, somebody's getting diagnosed with cancer. Um, since you study this stuff, talk about that, I guess, for a minute, if you will, and why we're seeing so much of it today, and maybe some things we can do to prevent it before, you know, we ever have to come see somebody like you.
Sure. So I think for many people, and for myself included, until I really got involved in studying it, it seemed almost an impenetrable, complex issue, so hard to understand. And maybe providing this overview will give more access to understanding. And if we think of the cancer cells as starting out as normal, healthy cells, that through exposure to some adverse conditions, and that can be infection, that can be toxic molecules, or other toxic exposures from the environment. It can be chronic inflammation. There's a whole range of adverse conditions called dangers, and that's actually what is called in the literature a danger signal, that can cause malfunctions. And the malfunctions can occur in the DNA, and the DNA can be the DNA in the nucleus. It can also be the DNA or other activities in the mitochondria, and that can have a vicious cycle effect, where there's a feedback effect where the normal DNA that makes RNA, that makes protein, can get disrupted. And so this normally exquisitely orchestrated feedback mechanism among many different pathways of production of DNA to RNA to protein can now have dysfunction, such that some of the protein accumulates too much or not enough. And the feedback, which would normally either turn off or turn on, is lost. So that now there becomes a lot of dysfunctional accumulation in a cell. And usually what will happen is the cell will collapse. The cell will automatically collapse. It's called automatic programmed cell death. You can think of it as a safety mechanism that nature has for cells that have become dysfunctional. Once in a while, the normal signaling activity, and by signaling, I mean very simply, and I'll use a non-scientific way, is if one hand is a molecule and the other hand's a molecule and they get close enough together where they exchange information, that is a signal. And then this one signals the next one that signals the next one in a molecular signaling pathway. And now we have hundreds of these pathways. And some of the pathways are associated with growing the cells. And some of the pathways are associated with stop growing the cells, because cells are finding where they're supposed to be. They're connected with each other. They grow to the right size and shape, and they're doing their function, and they stop growing. And that's normal. Well, when the stop growing signals are lost, they're no longer functional, and the growing signals are turned on, we now get this grow, 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 grow until it reaches a threshold size that triggers division. Now we have two downstream progeny that are from that upstream parental cell, and they then grow, 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 divide, accumulate, grow, divide, accumulate. And along the way, the cancer cells, in order to establish enough size and to still be able to survive, need to recruit three other categories of cells that are good, normal, healthy, necessary cells that exist throughout all of our organs, throughout all the body, fully distributed. And these classes of cells are recruited by the malfunctioning now cancer cells to assist the cancer cells in survival. These are three categories, and it's important, I think, that we raise greater understanding about this. The first category is called stromal cells, and these, you could think of them as structural support cells, and they provide structural support and other maintenance molecules. The next is immune cells, and the immune cells that get recruited are the type of immune cells that generally counteract good inflammation. So good inflammation is the response of the inflammatory system to infection, to trauma, to foreign molecules, toxic molecules, poisons, antigens that are harmful. And that when the good immune system, good inflammatory immune system contains that danger, then that danger containment system of good inflammation is turned down or turned off with good anti-inflammation. So the good inflammation is suppressed by the good anti-inflammation. Well, the cancer cells exploit that. The cancer cells produce immune messenger molecules that not only recruit these stromal cells for support, they also recruit the good anti-inflammatory cells that are now forced to migrate from other parts of the body, from the bone marrow and from other organs, literally to the area where those immune messenger molecules, chemokines or cytokines produced by the cancer cells, are in their highest concentration. So now the cancer cells have stromal cells next to them, and these good, now kidnapped and forced to be bad pro-cancer immune cells that are the anti-inflammatory immune cells, so that when the good anti-cancer immune cells that can kill cancer cells come floating along, though anti-inflammatory immune cells, which have been kidnapped by the cancer cells, suppress them. And that means the tumor, the grouping of cells, now avoids immune destruction. It's a camouflage mechanism. And then when the tumor population gets big enough, at the center of it is a low oxygen amount, hypoxia. And that causes the cancer cells, like any healthy cells, to try to survive by producing molecules to induce the growth of blood vessels. So now we get those stromal cells, the immune cells, and the vascular cells, which are now uh, in plexed or connected in a network to support the cancer cells. So at the center of this, our emphasis is on the cancer cells and cancer stem cells, which are doing this recruitment of other cells in order to survive. So yes, we want to focus on the central uh, um, malfunction malfunctioning cell, which is the cancer cells and the cancer stem cells, and we want to broaden our scope to include these other cells in the tumor microenvironment, and that's the term for it, that are also interconnected as a network plex. I call it a plex connected network of cells because they all send molecules back and forth among each other in order to further provide survival for the cancer cells. The cancer cells can survive, but they're not going to be a big tumor unless they have tumor microenvironment cells to allow them to avoid immune destruction.
Okay. Yeah. So thank you for all that. That's a good description. So how can we, before we talk a little bit about some of the treatments that you do, how can people prevent cancer? Kind of knowing all that and how
Yeah.
cancer works.
So,
What are give us some tips on maybe how we can prevent it in the first place?
so identifying if you can, and a lot of times people get change from a healthy cell to a malignant cell, that transformation, and we don't know why, and we're not going to know why in that particular person because it could be from toxic accumulation, something in the environment, or it could be from infection, or it could be from some other reason, radiation, some other degradation. But that the idea for prevention is to optimize your immune function so that you're at the most efficient ability to have that good danger monitoring, good inflammation that can identify adverse conditions and then clear them up, clean them up. So, from a dietary point of view, it's eating as cleanly as you can, identifying when you do eat, if you have adverse, some minor adverse symptoms from the food, and minimizing the ultra processed food, which have very small molecules that can potentially accumulate in cells and cause more inflammatory reactions. Um, the standard advice that is well said of sleeping well and good exercise, and I think of very high importance is optimizing your relationships to make them as healthy as you can, and being aware of your exposures in your environment, whether it's the workplace, whether it's at home, but meaning chemistry in the environment. Are you using any chemicals, whether it's cosmetics or things in your cleaning solutions or anything that you are physically exposed to that you can modify that can be more naturally processed through your system? Minimizing the overload of empty calories is also very helpful, because anything that's perpetuating chronic inflammation, theoretically, it perpetuates or increases that risk. Similarly, I think we're now starting to come into the idea of optimizing the microbiome, the population of microbes in the gut, in the bowel, from the mouth on down to the other end, as well as on the skin. But primarily, I think the most work is being done on the microbiome in the gut tube from the mouth on down, and looking at optimizing that. I think we're in some pretty early days for that, especially with regard to cancer management. But the message that I will offer is that some of those microbe populations are producing molecules, immune messenger molecules, that increase the good inflammatory anti-cancer molecules, and some of them produce the in the gut good anti-inflammatory molecules. But if someone's got a diagnosis of cancer, then those can actually wind up working against them because they can feed that tumor microenvironment. There's a big, very fundamental difference between prevention and treatment. And when we're talking about prevention, I think those anti-inflammatory approaches are very helpful with microbiome. But if there is a diagnosis, then I think significant caution needs to be taken. So the take-home message is prevention is very different than treatment. And in prevention, attempting to be as clean and clear and physically active and sleep well and eat with the least amount of extra molecules of additives, preservatives, things I think that are pretty commonly discussed in the functional and integrative medicine community, and more within the conventional mainstream medical community. I hope that gave an overview
Yeah,
that
for
was
sure.
helpful.
Yeah. Thank you for that. And that's a good segue into the treatment aspect. And I know we can't, everybody's diagnosis is different, and I'm sure you have a ton of different protocols depending on the specific types of cancer. But are there some general things that you can go over as far as treatment that you can recommend, or that you generally recommend, that will target those three types of the molecular process that you described?
Yeah, so it I think it's helpful for people to have a better understanding of the malfunctioning and how we can help restore healthy function. So, of those four categories of cells in the tumor microenvironment, each one of those cells has multiple pro-cancer molecular pathway activities. And each one of those cells are producing molecules that on the inside of the cells perpetuate that, but also are produced and exchanged between each of the other cell types in the tumor microenvironment. And so a way to say it is that each of the cells in the tumor microenvironment, each of the cell types, classes, cancer, stromal, immune, vascular, in and between those have pro-cancer molecular activities in which we can identify in the preclinical trial data. So the data that is from the science of human and animal cancer cells in test tubes and in animals. So it's not the gold standard clinical trial data. I'll talk about that more so in a moment. But that from the preclinical trial data set, that there are these data that show the anti-cancer molecular interaction counteracting these pro-cancer molecular pathway activities. And so the strategy is to look at the evidence base, the preclinical trial data, and identify the pro-cancer molecular pathway interactions and counteracting them with anti-cancer molecular interactions from natural products and repurposed pharmaceuticals. Again, always in addition to the conventional oncology treatment, not instead of. And one of the great values of the natural products and most of the repurposed pharmaceuticals is they target multiple molecular entities, multiple molecular interactions simultaneously. So if you can get multiple distribution of those molecules, you could theoretically target multiple molecular pathways at the same time. The very significant limitation of natural products and the repurposed pharmaceuticals is that in isolation by themselves, they are not strong enough. They don't have enough therapeutic impact. It's called therapeutic index. So by themselves, they have a negligible effect. However, the data points very clearly to adding concurrently. So additive effects and synergistic effects. And if we then take a perspective, a viewpoint, essentially like going up and down, scoping up and down on a Google Street Map, but we're going to scope up and down on a tumor with the tumor microenvironment and look at molecular pathways and then come up higher and look at that. What we're looking at is molecular networks. And these networks of molecular interactions inside and between these cells, if we overlay upon them the multi-targeted, or another way to describe it is molecular network targeted natural products and repurposed drugs, and layer them concurrently for additive effect and synergistic effect, we can aim at some of the dependencies that these cells are communicating about, so that we can now put a relevant, clinically manageable, clinically important, clinically valuable molecular network synergy to control the progression of the cancer by controlling the molecular networks in the cancer cells and the other cell types in the tumor microenvironment. So there's a relevant rationale for using these data from the preclinical trial data set. One of the biggest challenges is understanding how the medical profession is organized. If you think of the medical profession as a big medical union with trades and subtrades called specialties and subspecialties, the medical oncology subspecialty uses the gold standard data, the data that comes from clinical trials in humans. And to be clear, it is the best data we have. I think of it as the top of the data mountain, the gold standard, and that those to get a single drug approved by the FDA to be marketed for a particular anti-cancer usage, the $500 million estimate is a conservative amount. And that's a massive undertaking to get one of those drugs to be approved. The way they get to that data, before they make the selection of what are we going to attempt to run through clinical trials, is they first look at the data where cancer researchers in the laboratories, who can use any molecules they want, they first in human and animal cancer cells in test tubes apply natural molecules, apply other chemicals, and including drug molecules or any molecule they want, to determine whether the result is pro-cancer or anti-cancer or no effect in cancer. And from that data, they then go to the next step, which is human and animal cancer cells in animals, and apply molecules to determine pro-cancer, anti-cancer, or no effect in cancer. And from that data, the pharmaceutical companies now have the ability to survey that data and say, well, there's an important anti-cancer molecular effect we want to get, but that's done with a molecule that's not patentable. And we need to be able to fund $500 million studies. So we need to have those molecules proprietary. And that means they then take those molecules and can modify them into vast libraries, hundreds, even thousands of variations, which they can have proprietary rights for. They own them, and they can patent them if they choose, and then run them back through human and animal cancer cells in test tubes, then in animals, and then decide among those for one or two or three candidate molecules to run through clinical trials in humans. The standard of care of the medical oncology profession is that anything from clinical trials on up to actually approved cancer drugs, that's the toolkit that they can use. They're not permitted to go below what I call a red line to the middle of the data mountain, the base of the data mountain, the human and animal cancer cells in animals, and in test tubes, which taken as a group is the preclinical trial data set. And those data, to be also clear, are less certain. They are statistically inferior to the gold standard clinical trial data. There's no question about that. And that doesn't mean it's completely irrelevant. What it means is, with informed consent and full disclosure, looking at the data that we have in the preclinical trials about products that are already on the market, natural product supplements and repurposed primary care and secondary care drugs, many of which are generic, and about which, especially the generic drugs about which we have an enormous amount of data about safety, about dosing, about half-life, about binding affinities, about a very broad range of information about the chemistry of those drugs and the effects in people, that we have these data that the medical oncology doctors aren't permitted to use. They're not educated about it through no fault of their own. That's where the profession has decided is the boundary. And so I think that it's important that we acknowledge that. And also now, instead of what the medical oncology doctors call preclinical, because that's from their side of the red line, from their side at the top of the mountain, everything in the middle and base of the data mountain, the in vivo human and animal cancer cells in animals, and in vitro human and animal cancer cells in test tubes, everything there from their perspective is called preclinical. And you'll see that in the literature all the time. I think it's more accurate to describe it as preclinical trial, because these data in the preclinical trial data set are already being used in the clinic by functional and integrative medicine doctors for making anti-cancer protocols, as I described earlier, a broad spectrum of natural products and repurposed drugs for these molecular network targeted therapeutic scenarios, strategies to control the progression of the cancer. I know that was a long-winded response, and it's, I think, important for people to have that grasp so that they can communicate with their physicians as well as among each other, so that they can make some decisions about that.
Sure. Can you comment at all on some of these repurposed drugs? Again, I know it's going to depend on the types of cancer as far as, and everyone's going to probably have a little bit different protocol, but most people, especially ones that listen to this podcast, are, familiar probably somewhat with, the fenbendazole and ivermectin and, even metformin, and maybe, sometimes higher dose melatonin is used, and there's all kinds of
Sure.
things out there. Can you comment on some of those that are usually in your protocols, or what are some of these repurposed drugs that you're referring to?
Sure. So a common class of drugs used is NSAIDs, non-steroidal anti-inflammatory drugs. And most people are familiar with ibuprofen. There's a more focused drug called celecoxib, or Celebrex is the brand name, and it's has a vast wealth of anti-cancer data. NSAIDs have a vast wealth of anti-cancer data. The challenge with NSAIDs is whether you tolerate it or not. NSAIDs can be really harsh on in their effect on the GI tract. They can, I'll use a non-scientific term, they can scorch your gut lining, scorch the stomach, or scorch the inside of the intestinal tract. And so everything has a potential benefit and a potential risk, and we need to keep both of those in our minds and when we're making decisions. Another class of drugs that have robust anti-cancer activity are the statins. And a lot of folks are unfamiliar with that part, but that the statins can be used for their anti-cancer effect, and that there's again, a very large amount of data for anti-cancer activity with the statins. These are common drugs that are very commonly prescribed by family practice doctors or other primary care doctors. You can look at some of the antihistamines, the antibacterials, antifungals, the antiparasitics, and you mentioned fenbendazole. Fenbendazole is a drug that is approved for veterinary use. It has a very close, what we could think of as a first cousin drug in human use called mebendazole. Both of those, and then there's another one called albendazole, but all of those have the molecular effect of interfering with the action of microtubules. Here's an example. So if someone gets a parasite and they're getting the mebendazole treatment, the amount of treatment that they get is a very short duration of treatment. So they'll get treatment for a few days because the parasite that needs those microtubules can have those microtubules. Think of microtubules. The way I think of it is tent poles holding a tent open, but microtubules are little tubules. It's like a spiral, almost like a spiral straw of these little almost ball-like units of molecules that now make this long tube that can help hold the cell structure open, and it also they help during cell division and moving the DNA, the chromatids, moving them. They have a lot of different functions within the cell, and they have to bind together, and then they have to pull apart in a certain orchestration. And mebendazole and fenbendazole work by interrupting the microtubule dynamics. And when you have a diagnosis of parasitic infection, once that parasite's gone, you don't need the microtubule dynamic management. You don't need the drug for extended duration. But cancer's a different molecule. I mean, cancer's a different setting, a different circumstance. And the drug is affecting the same molecular site in the cells, in the cancer cells, and it can do so in a manageable way. It has a quite good toxicity profile. And while as a licensed medical doctor, I'm not able to prescribe or even recommend fenbendazole, what I can say is that the mebendazole is a very similar action. And those are the ones, for instance, if I'm going to include that class of drugs, I generally am including mebendazole. Ivermectin has different mechanisms of action. Then there are other items that work at different sites, interfering with the intake of some molecules or the processing of some of the metabolic activities inside the cell. And so if we look at these drugs that are already approved and realize that they're given an approval for a particular usage, and that's what most doctors learn, but that once they're on the market, they're available, that doctors can search the literature and use them for other reasons for which the doctor has rational, supportable, logical reasoning, then we have this enormous additional resource of toolkit of these additional drugs. Many of them, most of them that I prescribe are generic, or that I'm developing the treatment plans for the doctors. They're generic, they're low cost. We have a very significant history of use. So we know how they work. We know how they affect people. We know about the important drug-drug interactions with other drugs. And so we can make very reasoned choices of multiple drugs, not just one or two, but a list of 4, 5, 6, 7 or more drugs, always beginning in the lowest dosage increment. and making sure that they're well tolerated before any kind of dosage escalation. And that doing that in this reasoned way, targeting the molecular networks, is, I think, a very natural expansion of using the resources we already have available. We have them on the market. Physicians have the ability to prescribe them. This is called off-label prescribing. It's perfectly widely done in cancer treatment. About 30% of cancer drugs prescribed by oncology doctors for other cancer treatments are repurposed cancer drugs. The functional and integrative medicine doctors are not generally going to be prescribing cancer drugs. So if the drug has the approval for cancer treatment, almost always it's the oncology doctor who's going to prescribe that on label, meaning for the reason it was approved by the FDA to be marketed, or off label 30% of the time. The non-oncology drugs, the primary care drugs, the functional and integrative medicine licensed prescribers, MDs, DOs, nurse practitioners, physician associates, physician assistants. And in some states, even naturopathic doctors have the ability to prescribe, that they can prescribe those items as well. And I think that's a way to beneficially harvest or beneficially exploit the data that's already there, and apply with a wider scope in order to also, in addition to targeting the cancer cells, target these other cells in the tumor microenvironment, all of it concurrently. And so it's a rational way forward. I think it's inevitable that this will continue to expand, that physicians will be more interested in it. And as more patients learn and their families learn more about it and requesting access to this information and these therapeutic tools, these pills and powders and liquids, that we're going to see more and more of it. I think the biggest challenge is understanding potential drug-drug interactions and having a very high-grade, high-quality professional drug-drug interaction analysis when a treatment plan is being initiated.
Mm-hmm. There's all kinds of things out there, especially when it comes to alternative treatments in cancer. And do you, when you're setting up protocols, do you utilize some of these other things, such as maybe some prolonged fasting, especially around the time of chemo? And there's ozone therapy. There's even some patients I've maybe tried, like methylene blue. I mean, there's all kind of things. I mean, do you incorporate some of these things in your protocols as well, or just focus more on the repurposed drugs?
Yeah, so because I'm collaborating with local physicians around the US and Canada, I keep my scope of recommendations in the treatment plan that's being developed to be with eating guidelines, natural products, and repurposed pharmaceuticals. I can give my opinion or recommendation about other things. So you mentioned IV therapy. I think high dose intravenous vitamin C has very good support, very good data. It's a reasonable, rational approach. Other subcutaneous, for instance, subcutaneous or even intravenous with mistletoe has a lot of good data and good outcomes. I had been using mistletoe in my clinic since the early and mid 90s. Other therapies, fasting is a cornerstone, especially, or it doesn't have to be full fasting. It can be the fasting mimicking diet, which can be done pre, peri, and post chemotherapy. So just before, during, and after chemotherapy. And there's multiple ways that can be done with multiple different dietary approaches. I don't think there's any one diet that is fully applicable across the board for everybody. I don't think the data supports that. The calorie reduction is a reasonable method to incorporate, regardless of the type of diet that's being used. The challenge is the data that supports calorie reduction in animals is such a high degree of reduction, down to from 100% calorie intake for these animals, they put them down to around 60%. You're not going to do that in a person, not for an extended duration.
Hmm.
So the challenge becomes, well, how much reduction, for instance? So you asked about how I might recommend. So what I say is, well, when someone is considering and willing to adopt a calorie reduced dietary method, look at their body mass index. So what, how tall are they? How much do they weigh? What's their gender? So essentially, how much would a normal range of calories be from a low amount of calories to a high amount of calories for someone with that body mass index?
Hmm.
And choose the low end, and maybe even just a little bit lower than that. Take some getting used to. And just remember that this is what I've told my patients for years is you don't have to do it. You get to do it. It's
Hmm.
something you get to choose, and you don't have to do it all the time. You can modify it. You can change. You can make exceptions. It's a method, an approach that gives you greater likelihood of benefit than if you didn't think about it at all, and if you didn't then make those choices. Also, generally, when you look at the data, the cancers, they are highly avid for glucose, carbohydrates that get broken into glucose, and they're also highly avid for glutamine. And glutamine is an amino acid that's the most common amino acid in all protein. And you're not going to have a diet low enough in glutamine to cause anti-cancer effect, but you can have a diet low enough in carbohydrates to have an anti-cancer effect. We commonly call that a ketogenic diet, and you can have a ketogenic diet that puts anti-cancer stress on the tumor. And some people are very happy to do that, and others find it more challenging and sometimes struggle with that. So, what my recommendation in general is in that circumstance is aim for low carb and be at the flipping in and out of ketosis, for instance, rather than some folks are really able to go to a full high ketosis, a very extensive ketosis, but it doesn't mean that everybody has to. You do the best you can. And so often using a type of modified Mediterranean low carb diet.
Hmm.
And some folks are doing intermittent fasting. And I think that makes sense. I think the data about intermittent fasting is not quite as good as the fasting mimicking diet for during chemotherapy. I think that Dr. Longo has done a really good job with that, pursuing that information, but that it's still reasonable. Lower calorie intake, clean, good, healthy calories. You need to a modified Mediterranean diet that is low carbs, and managing the best you can without feeling stress emotionally if you are not in a full a full ketogenic diet. If you can do it, some of the diets, some of the diagnoses, I think it has very good data. For instance, in some of the brain tumors, glioblastoma shows some significantly good data for ketogenic diet, but other diagnoses not necessarily so. And
Hmm.
so emotional and mental well-being is very closely connected with dietary intake. That's the biggest habit we have is eating foods. We've been
Hmm.
doing it forever. And so changing that can be very challenging. And so I want to encourage people to be gentle and compassionate with themselves and their family members, um, when they're managing and making dietary, nutritional modification.
Hmm. Well, perfect. Well, that's a great way to kind of wrap up here, I think, and appreciate all that information just about cancer, more kind of on the molecular side of it. Uh, so your website is LaValleyMDprotocols.com, and I'll have that in my show notes. Is that the best way to get a hold of you for people that might want to, work with
Yes.
you? Perfect.
Yeah, absolutely. They can reach out, and then we can, if they want to have a discussion, we can schedule a Zoom meeting. And I think it's a way that people can locally manage with treatment plans that the doctors are comfortable with implementing.
Hmm.
Not every clinic has IV therapies or hyperbaric oxygen. All of those things are supportive, and I strongly support those methods of treatment. That that doesn't mean that someone has to go to a clinic that has those, because there are a lot of physicians, integrative medicine physicians, who are happy and able and have the expertise to implement these treatment plans, and I'm happy to and eager to collaborate with them.
Yeah. Well, very good. Well, appreciate that. As we wrap up here, I always ask my guest if they could give us one health tip that would make us healthier today. What would you say to that?
Um,
Sometimes it's hard to pick one.
yeah, I think engaging in the goodness that's inside you with the goodness inside others. I think that's the healthiest thing that we can all do.
Okay. All right. That's a deep statement right there. Very good.
Thank you for
Well,
that. Thank you for
yes.
that.
Well, thank you so much for just your research and what you do. That's just such an important topic and one that just especially in the physician community, I feel like just they need to be more educated and just some alternative things that can help because definitely I know people are looking for that, and so I wish more of their other doctors and their oncologists were more supportive of that instead of just, I feel like many times they just kind of squelch it. But, you know,
Well,
uh,
I think it's growing, and I think the more people ask for it, the more it's going to uh, become more available. And so I encourage people to persist in asking and recognize that they have the right and the choice, and that patient-centered care, which we're all agreed to in the American Medical Association.
mm,
Patient-centered care means the patient's preference matters, and the patient's participates in decision making. And so I always tell my folks, the people that I collaborate, I mean, the people, my own patients or other doctors' patients, is your doctors are managing you and you are managing your doctors, and see it as a two-way relationship. And so I think that brings better outcomes for everybody.
yeah, for sure. All
Thank you
right. Well,
very much.
Dr. William LaValley, again, appreciate that and appreciate everyone listening. And we will talk to you next time.
Thank you.